Tech India welcomes all the participants for today's Regional Distance Learning Seminar Series. Today's topic is post-exposure prophylaxis for HIV, and the speaker is Dr. Prasenjit Saha. Dr. Prasenjit Saha has completed his MBBS and Diploma in Maternity and Child Welfare and Fellowship in HIV Medicine, and is currently working as a Senior Medical Officer at ART Center, Medical College and Hospital, Kolkata. He has worked with various organizations in the field of community health, STD and HIV, sexual health, and drug use disorder. He has been an expert master trainer under Saksham Global Fund Round 7 of the University of Kolkata. We welcome you, sir, for today's session and request you to start the session.
Thank you, madam. Good afternoon, everybody. Hope I am audible?
Yes, sir.
Okay, fine. So today's topic reads post-exposure prophylaxis for HIV. Next slide, please.
So you will have to just click on the next button.
Okay, yes. Ma'am. So session's objectives are to understand the need for a system of post-exposure prophylaxis, enumerate the illnesses transmissible occupationally, evaluate a healthcare worker sustaining an injury and prescribe the appropriate PrEP, and discuss the follow-up procedures after PrEP. Post-exposure prophylaxis for HIV. At the outset, let me tell everybody, PrEP is an umbrella word. It's like a basket full of different kind of fruits. So we should not think PrEP is equal or equivalent to PrEP drugs. So as I have just mentioned, it's an umbrella word and there are a lot of things, a lot of aspects attached to it. So why talk about PrEP? Because HCP are prone to accidental exposure to blood and other potentially infectious material. And while doing the job duties, there's always a risk of getting infected by HCV, HBV, and HIV. And why should we bother? The reasons are this total scale-up of HIV testing and ART services all around the country. And PLHV survive longer due to ART. Naturally, the more they survive, there'll be much more interaction between healthcare providers and PLHIV. Next, PLHIV increasingly utilizes healthcare facilities for their health needs, and there's always an increased risk of accidental exposure to HIV. HCP include emergency care providers, lab personnel, mortuary staff, lab staff, everybody at different levels of healthcare system.
Excuse me, sir.
Yes, please.
Sir, the screen is not visible in full screen mode. Is it okay if I share screen from my end?
Absolutely, ma'am. I'll just say next slide.
Yeah, give me 2 minutes. Sir.
Okay, ma'am. Ma'am will change the slide.
Stop share. Yeah, please stop share kar dijiye.
Oh, stop share kar dijiye, bol, madam. It's not full screen.
Yeah.
Ma'am, it's not full screen.
Yeah. Give me 2 minutes. Sir.
Okay, ma'am. Okay.
Is it full screen now, sir?
No, ma'am. This is full screen now, ma'am. Okay. Can I go to slide number 4? Next slide, please.
Is the 4th slide visible, sir?
Next slide, please. This is in full screen, ma'am. The next slide, please. Fine. So let's, thank you, ma'am. So there's certain definitions we need to sort of, know about. Who are healthcare personnel who are paid or unpaid worker working in the healthcare settings and exposed to all potentially infectious material. And what is an exposure? This may take place by healthcare personnel at risk for bloodborne infection, and the risk of acquisition of HIV from a hollow bore needle with blood from a non-HIV seropositive source is between 0.2% to 0.5%. And what is an occupational exposure? Getting exposed to all this potentially infectious material while on their job duties. There are a chapter known as non-occupational exposure. What are non-occupational exposure? This includes sexual assault as well as unsafe sex. Next slide, please. Next slide. Right. So definitions continues. What a needle-stick injury? It is an umbrella word or a broad term that consists of injuries, percutaneous injuries caused by sharp objects, which includes glass vials, surgical blades, needle, scalpel, etc. And there has to be a puncture wound. And who is an exposed person? A person who is potentially at risk for acquiring HIV and other bloodborne pathogens while doing their job duties. And who is a source person? Who is either identified or not identified as a possible source of the potentially infectious material. Next slide, please. Who is at risk? Everybody who is working at the healthcare settings, from nursing, students, doctors, professors, physicians, interns, dentists, mortuary servs, cleaners, waste handlers, everybody. Everybody is at risk, including people visiting, family members visiting healthcare setups. Next slide. There is a question, who is at a higher risk of infection? So let me talk about two options. Who is at a higher risk of infection? A healthcare worker during disposal of sharps from the obs-gynae theater has a prick on his finger after a positive delivery. B, an internist had a splash of pleural fluid on his face from a HIV positive individual. So my question is, who is at a higher risk of infection? We do agree both are prone to infection, agreed, but who is at a higher risk? So please ponder. I'll give you a few seconds to think about it. And in the chat box, please write A or B. Please take your time. Are there any replies in the chat box?
Yes, sir. There's answer A.
Oh, okay. Everyone said answer A. So let's see whether the answer is correct or not. Let's go to the next slide. Exactly. Let's come to who is at a higher risk of infection. Let's go to the next slide, please. Next slide, please.
Is the slide visible? Risk of exposure?
Exactly. This is right, ma'am. Thank you. The risk of exposure from different body fluids. If you know this, it would be easier to answer that question. And all of you are correct, by the way. Thanks to everybody. So exposure to body fluids considered at risk, and there are body fluids which are considered not at risk unless and until these fluids are contaminated with visible blood. So at risk body fluids include blood, semen, vaginal secretions, cerebrospinal fluid, synovial, pleural, peritoneal, pericardial, and amniotic fluid, and other body fluids contaminated with visible blood. And not at risk fluids includes tears, sweat, urine and feces, saliva, sputum, vomitus. But once they are contaminated with visible blood, they are considered at risk. Next slide, please. So HIV transmission risk by different routes. So what are the risk factors? When it's blood transfusion, chances of transmission is above 98%. So blood is an important category. It's a one very important source of transmission. Perinatal without any intervention means without any ARV, it is around 20 to 40%. During sexual intercourse, it is around 0.1 to 10%. Vaginal, it is 0.05 to 0.1%. Anal, it is 0.065 to 0.5%. Oral, it is 0.005 to 0.01%. Injecting drug use or people who inject drugs, it is around 0.67%. Needle stick injury, this is very, very important for healthcare providers. It is around 0.3%. Whereas mucous membrane splash to the eye, oronasal, or any splash on any abraded skin, it is around 0.09%. While talking about HIV, we need to keep in mind about hepatitis B and hepatitis C. Let's see what was the comparative study. The risk of needle stick injury to HBV is around 9% to 30%. And for HCV, it is around 1 to 1.8%. But remember one thing, I'm going to talk about a ready reckoner. For hepatitis B, which is the highest, you can remember 30% at one go, it's a ready reckoner, 30%. For hepatitis C, you can always say 3.0%. For needle stick injury for HIV is 0.3%. So it's easy. HBV 3.30%. For HCV is 3.0%. For HIV is 0.3%. Thank you. Next slide, please. Risk depends on two parameters. One is type of body fluid. The other is route of contact or exposure. Next slide, please. There's another case. Let's go through this case, and I would give you some time to ponder. A medical officer in an ART center presents to an emergency care for evaluation of a needle stick injury 2 days ago while inserting an IV line to a HIV positive patient, right? The question is, next slide, please, ma'am. Can you start PEP in this situation? He was not in the ART center. He was working in the ward, and he had a needle stick injury, and the line was inside the veins, the intravenous. So the person is HIV positive, and the source is HIV positive, and it happened 2 days ago. So should you start PEP in this situation? Is the healthcare worker eligible for PEP? Please think about it. And I can say Kavita Majumdar said yes. And anybody? Please think about it. Let's pause for a while your thinking machine is on. Yes, everyone, Sanchayita, to everyone, yes. So answer is yes. So let's see whether they are correct. Please, can we go for the next slide, ma'am? Things to know before starting PEP. Whenever we do something, there's some logic, some baseline knowledge for the consequences we do, for the management we do. What is the risk for contracting HIV while having a needle stick injury? One has to keep that in mind. Are there factors that might affect this risk? Very fair enough. How effective is PEP? Is it 100% sure? Is it too late to start PEP? The other person said the medical officer wants to start PEP after 2 days. So is it too late to start PEP? What are the drawbacks of starting PEP? There are multiple regimens. Which regimen should be considered? What follow-up management should be arranged for this patient or healthcare workers? So we need to know everything, and we'll be diverging as we grow further. Next slide, please. What is the risk of contracting HIV infection? Next slide. Average risk of Hep B, Hep C, and HIV during an occupational exposure, as I've just mentioned. Percutaneous injury for HIV is 0.3. Hepatitis B is 9 to 30%. HCV is 1 to 1.8%. I have said that. For HIV is 0.3. Hep B is 30%. For HCV, remember 3.0. Is it remember? And any kind of mucous membrane exposure over the eyes and over abraded skin, it's 0.09%. Next slide, please. Risk factors for seroconversion. After the exposure, what are the risk factors? So the risk factors are deep injury. What are the odds ratio? It's 15. It's quite high. It's a deep injury, mind you. Visibly bloody device. The needle that had come in contact with your body had blood on its surface. There was blood. So the odds ratio is around 6.2%. Device was in artery or a vein, direct. It's around 4 to 4.3% the odds ratios. And terminally ill patient was 5.6%. But when you take PEP, AZT is, all of us know zerovurin. It's an animal study long back. So the odds ratio is very less. It's 0.19%. So the moment you take PEP, chances of getting the seroconversion is quite less. It is never zero, but it is less. And there are a lot of factors that comes into play. Next slide, please. Other likely risk factors are viral load. We know more is the viral load, more is the chances of transmission. Glove use, it's a barrier method. It's a barrier. It's part of our standard operating procedures. So 50% decrease in volume of blood transmitted. hollow bore versus solid bore needle. Hollow bore has a lot of blood, the volume is more, and more volume means more blood, and solid is less blood and chances of infection is less. Drying conditions, there's always a tenfold drop in infectivity every 9 hours. Next slide, please. Management of the exposed person. What are we supposed to do? Steps to manage the exposed person. So what I said initially at the outset, remember, PEP is an umbrella word. It's a basket full of lot of issues. First is when you talk about management of the exposure site, first aid. But before that, what I would suggest is calm down. Do not panic. I have been working in this field for a very long time. So I have seen people crying, healthcare workers crying. They're so in a panic mode. They don't know what to do. So calm them down. Stop what you had been doing. Call out for help. Ask your colleague to come near you. Stop what you had been doing. And first aid, emergency management of the exposure site. Next is establish the eligibility for PEP drugs. Counseling for PEP, which is very important. It is just not writing PEP only. It is counseling. He or the patient has to go for the PEP drugs. Assessing the need for PEP and prescribing PEP. Lab evaluation and follow-up management of the exposed person. Next slide, please. Management of the exposure site. First aid, skin. Can I have the full? Exactly. Let's get back to skin. So immediately wash the wound with surrounding area with soap and water or normal saline. Do not rub or put any caustic medicines, antiseptics, betadine, chlorine, alcohol. The moment we do that, what we do, we sort of irritate the part. The more irritation to the part happens, there will be inflammation to the part. And as we know, more inflammation means what will we do? We'll call for help. We'll call for backup. And what is backup? Lymphocytes. They'll just come running to that site. And more lymphocytes means more T lymphocytes, CD4 cells. And if there's at all viruses in the blood you have been exposed to, the healthcare had been exposed to, it will rush and immediately get attached to the CD4 cells. So no, not using caustic material, not using antiseptic, soap and water, normal saline is good enough. Next slide, please. If it is an intact skin, it is just soap and water and is good enough. I need the whole slide, please, ma'am. Whole slide. Thank you, ma'am. Let it be there. So wash the area immediately. No use of antiseptics. Unbroken skin. We know skin is a barrier, so we are not scared at all. So there's no chances of transmission. But if there is an abrasion, we'll do accordingly. I've just mentioned. Regarding eye, when there's exposed to the eye, irrigate, clean it with water. It can be water or normal saline. No soap or any astringent or any other fluids is necessary. Ask the healthcare provider to sit on a chair and tilt back and ask your colleague or the another colleague of yours to pour water and it will be washed off. Do it quite a number of times. If the healthcare provider was wearing a contact lens, let him or her wear the contact lens. And after sufficiently you have washed the eyes, take out the contact lenses, clean as it should be done, and ask her to wear the contact lenses again. Do not use soap or disinfectant on the eyes, I have mentioned. And if the splash was inside the mouth, spit out the fluid immediately, rinse the mouth with water or saline water. Do not use soap or disinfectant in the mouth. Next slide, please. Next slide. So what we're not supposed to do, which we do as a reflex action, put the finger in your mouth. Don't. Please, from now onwards, don't. Next slide, please. Now, establish the eligibility for PEP. And we should know, and we know, most of us know, it should be started preferably within 72 hours, rather as soon as possible. So this includes 3 stages. One is assess the severity of exposure and the risk of transmission. Assess the HIV status of the source of exposure. Assessment of the exposed individual. Next slide, please. So before doing that, let's categorize the exposures. We can categorize the exposure into 3 stages, 3 categories. One is mild, moderate, or severe. So what are the definitions of this? So number one, mild exposure includes exposure to mucous membrane or abraded skin with small volume, contact with eyes or mucous membrane, or subcut injection following small bore needles. What are moderate exposures? Exposure to mucous membrane with large volumes, with lot of time, percutaneous superficial exposure with solid needle, example, superficial cut or needle stick injury penetrating gloves. And what are severe exposure? Percutaneous deep injury with a large volume of potentially infectious material, high caliber needle, more than 18G, contaminated with blood, deep wound, accidental material that has been used previously on another HIV positive patient. There's a footnote. The wearing of gloves is one of the standard workplace precautions. Blood glove punctures do happen when we do not wear the gloves correctly. So this is very, very important. And in case of accidental exposure with blood, with materials such as sharps, dried contaminated blood, the transmission risk remains a weak for HIV, but the risk remains more significant for Hep B and Hep C, as this survive longer than HIV outside the body. Next slide. Categories of situations depending on the results of the source. So source of the HIV status, HIV negative. Source is not HIV infected, but consider hepatitis B and hepatitis C. Patient is at low risk. A patient is high HIV positive, but clinically asymptomatic. That means she or he is doing well. And high risk means HIV positive patient of the source and is clinically symptomatic. That means the patient might be in CIS 3 and 4, might be 2 as well. Next slide, please. Counseling for PEP. This is a very important pillar of PEP. Without counseling, PEP does not hold ground. So before starting giving PEP medication, that has to be kept in mind is informed consent. He or she should be told about the given knowledge about PEP, and it is his or her right to decline PEP or to continue PEP. She or he has to give in writing about the consent. Appropriate information has to be shared. Pros and cons about the drug has to be shared. Should be clear that PEP is not mandatory. The healthcare provider can opt out. Information on window period is very, very important. A patient, the source patient can be in the window period, but still can transmit HIV. Please keep this in mind, bear this in mind. And next is psychological support. First thing is, it is not about patient needs to be informed about the risks and measures that can be taken. It is about calming the patient down. Patient in a state of panic. Be with the patient, reassure the patient. Tell him about the pros and the cons. Tell him that it is the moment you have the needle stick exposure, definitely risk factors are there, but tell him, be with the person and try to calm him down. This is very, very important, and it goes a long way in helping the patient. And some may request psychological support. Documentation, like everywhere, it is very, very important. Special leave may be given from work if the patient has a lot of side effects. And recording, we have a PEP register from NACO that has to be maintained. This is very, very important. It's mandatory. Next slide, please. Assessing the need for PEP and prescribing PEP. Deciding on PEP regimen, which regimen should be given to whom, that is important. Availability and prescription for PEP. Whether whatever regimen you have decided upon, what you're going to write, it also depends on your availability in your center, in your institution. And vaccination for hepatitis B for all healthcare workers. It's a must. Please, I'm so requesting all ART centers, SMOs and AMOs to look into it, that everybody is vaccinated. And let's come to a case of sexual assault. PEP should be given to the exposed person as a part of overall package of post-sexual assault care. That includes STI package as well. And somebody might ask me, but the person, I do not know about the status of the sort of source person. We did not know about the source of the person because it was a violent act of violence against a person. And the moment there's an act of violence, it was a high risk activity. So naturally, chances of that person having high risk activity is more, and the person who is a victim warrants PEP medicine. So definitely we'll have to start PEP. And if we can get hold of the person, we can go for testing of ICTC of the source person, but after informed consent. In case of high risk exposure or non-occupational from a source person who has been exposed to or is taking ARV medication, we have to consult an expert to choose the PEP regimen, as the risk of drug resistance is high and a change of regimen may be required. What does this mean? Suppose the source person is already on ARV, ART, and you get exposure from that person. I'm talking about sexual assault. The regimen we have to tailor make. We cannot give the common medication that is available. We have to tailor make for that person. And people who are expert in this field has to be called upon, has to be contacted for giving them the medication. But that does not mean you wait till he or she gives you the answer. You start the general medication till he gives you the answer. Next slide, please. Evaluation of exposure sources. Known sources. You test known sources of Hep B, Hep C, and HIV antibody. Lot of patients, lot of healthcare workers comes to me and they say, without my prescription, they go to private labs for going for direct virus assays like proviral DNA, PCR, P24 antigen. But that is not recommended. That is not a gold standard. Always use a rapid HIV antibody test. And that is what NACO recommends. And do not try to, if the not infected with blood pathogen, we might not go for PEP. But remember, in these cases, if the sources are unknown, even if the patient is in window period, what we can do, we have to see the HIV prevalence of that particular area and see the high risk activity of the person concerned. So evaluate from a case to case basis. Another very important mistake that some people do not test discarded needles for bloodborne pathogens. We are testing blood, not needles or blood from the needles, please. Thank you. Next slide, please. When should PEP be started? Next slide. When should PEP be started? So efficacy of PEP thought to wane, that means come down with time. And what point is PEP no longer worth it? If you can see the graph, you see the benefits of PEP is coming down. After exposure, you see along with time, it's coming down and the risk increases. Next slide, please. So this is an animal study, the path of the HIV transmission in the host. After the exposure to HIV at mucosal surface after sexual exposure on day 0, around day 2, virus is collected by dendritic cells and carried to the lymph nodes. That is, virus goes to the lymph node. And this is primary viremia. And day 4 to 11, you see virus replicates in the CD4 cells. And from CD4 cells, it is released in the blood. And if you can culture the plasma, we can detect HIV in the plasma. Okay. So from day 4 onwards, day 3 onwards, we can detect the virus in the plasma. So that there lies the magic hours of 72. So the moment after 72 hours is very difficult. The chances of not getting HIV comes down. It wanes. It comes down. And from day 11 onward, virus spreads to other organs. Next slide, please. Timing of PEP. What's the evidence? Animal models suggest substantially less effective beyond 24-36 hours. And some says in each group receive PEP within 4 hours. So exactly, there's not a clear-cut cutoff, But we say, NACO says, CDC says, it should be within 72 hours or as early as possible. Next slide, please. If how long, there's a very, if some people come and ask me, healthcare provider, sir, we have to go for 28 days, sir. 28 days, sir. This is a very important question. So we have to impress upon the healthcare provider that yes, it is 28 days. So counseling plays a very important role. It's very pertinent question they ask. 28 days is not a joke. We don't even take Metrogyl for more than 3 days, most of us. But PAP for 28 days. So that's the reason there's certain animal models. There have been some animal studies. If we can, madam, can you put the arrow on the graph, please? Can you have the pointer on the graph? Thank you, ma'am. If it's, there are a lot of studies. If it's 3 days PAP, you see, it is around 50, seroconversions rate is around 50. 3 days PAP, seroconversions around 50%. Not very good. 10 days PAP, it is around 25, not good at all. But when it's 28 days PAP, it is 0. So it's better to take 28 days PAP because there has been an animal model, animal study that if you take for 28 days, it shows that chances will be 0. It is not 100%, but chances will be very, 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 very less. And because other factors comes into play. Next slide, please. Duration of PAP. We have just spoken about it. And as CDC says, which NACO has adopted, it has to be taken for 4 weeks, not 30 days, not 1 month. It is 28 days, 4 weeks. Next slide, please. Key consideration while prescribing PAP. PAP should be started preferably within 72 hours after exposure. There lies the sort of, what should I say? The magic of 72 hours. This is the golden opportunity, golden period. Because after 72 hours, the virus spreads from the lymph node. It can be detected in the plasma. So if the HCP presents after 72 hours, we cannot refuse, but tell the HCP through counseling that the efficiency comes down. So this is very, very important. PAP should be made available in the emergency department, labor room, ICUs, and OTs. And if any other places you can find, you think it is better to keep in those places, those wards, you better do. In medicine ward, you better do. And at the same time, everybody should know where you have kept the drugs. And that is the reason if you have a posters or notices put up at different places, this can be near the elevators, near the staff room, near the canteens, near the emergency rooms. If you sort of, paste them on the wall, it will be easier for the people to approach you. And because ART center won't be open for 24 hours of the day. Next, the exposed person should go to the designated clinic or officer at the earliest for a complete risk assessment for HIV counseling and PAP. So this is what I was talking about. And all hospital staff should know whom to go, where to go, and where to find PAP. Even if you've kept it in a different ward and people don't know, it doesn't make sense. So people should know because they should be aware of the fact that PAP are available in your health institution. Next slide, please. When to obtain an expert opinion. Delay in reporting exposure, that is after 72 hours. You can always take expert opinion. Nobody can stop you. It's your right, within your right to take expert opinion. But these are the guideline. So after 72 hours, more than 72 hours, you can always take guideline whether to continue with the patient, the healthcare provider reports after 72 hours. If the source is unknown, use of PAP to be decided on case-to-case basis, because it depends on the severity of exposure, the risk factors of the case, depends on whether the person is having high risk behavior or not, likely about the prevalence of the epidemiology of the area. So everything is important. For example, a person gets a needle stick injury in an ART center will be much more at a higher chance of getting in than any other places of the health institution. Source person is on ART, possibly might have drug resistance. So it is better to ask an expert. He or she can tailor make the regimen for you. But that does not mean you do not start ART or PEP drug. Immediately start PEP. Going to contact the expert person to tailor make the regimen for the patient, or not the patient, healthcare provider. Major toxicity of PEP regimen. Minor side effects may be managed symptomatically. Refer to expert for non-tolerance and non-adherence. That is very important, because refer to expert for non-tolerance and non-adherence. You know, at the onset, if you talk about the side effects and adherence, the healthcare provider would be in a better position to manage these things. If you do not talk about adherence and the side effects of this PEP drugs, he won't even know. It will be like a bolt from the blue. So it is better that you share at the onset, and he won't panic. So even after doing that, if you cannot manage the cases, it's always better you take expert's opinion and refer and consult if in doubt in complicated cases. Next slide, please. HIV exposure codes. HIV exposure codes, we call it EC in short form. Whether the material is blood or other potentially infected material, we have spoken about it. If it is no, PEP is not required because it does not carry virus. If it is yes, what type of exposure has occurred? If it is an intact skin, we know skin is a barrier, no PEP needed. If it is a mucous membrane or integrity compromised or abraded wound or eye contact, it depends on the volume of blood or potential infected material. If the volume is small, few drops, short duration, it is exposure code 1 or EC1. If it's a large volume, major splash, long duration, it is EC2. Let's come to the percutaneous exposure. It depends on severity. So again, we can divide into exposure code 2 or exposure code 3, depending on if it is less severe, solid needle, superficial scratch, it is EC2. If it is more severe, hollow bore and deep injury, it is EC3. Next slide, please. Let's come to source codes. SC, source of exposure, HIV status. HIV negative, PEP definitely not required. If the HIV status not known, source code is unknown. And HIV positive, we look at the low titer exposure, asymptomatic, high CD4 count. We call it HIV SC1. And the other options are high titer exposure, advanced disease, low CD4 count. It is HIV source code 2. Next slide, please. NACO recommendations for PEP for HCPs, depending upon or based on exposure and HIV source code 2. The first column has the exposure code, second column has source code, third column is recommendations for PEP. And if we have to take PEP, it has to go for 28 days, nothing short of it, and not longer than 28 days. So let's say if the exposure and source code is 1 plus 2, not 1 plus 1 is equal to 2. 2 is not required. Okay. And if you say 3 or 4, it is always required. Exposure code, you see, look at this, 1 plus 2 is 3, 2 plus 1 is 3, 2 plus 2 is 4, 3 plus 1 or 2 is 4 or 5. Their recommendation of PEP is made by NACO. So it's for 28 days. 2 by 3, when the source code is unknown, we do not know about the source person. So, but still we have to consider PEP if the HIV prevalence in that area, in that population is high. And so risk categorization is there. So in those cases, we have to take a call on case-to-case basis. You have to give for 28 days. But mind you, one thing is very, very important. There is a term called worried well. Even after telling the patient or the healthcare provider, you don't need PEP, you're okay. Even then, in spite of the counseling you do, patient will talk about getting HIV infection. They're so scared. They're in a panic mode. So those patients are known, those healthcare providers known as worried well. In those cases, you have to think about giving PEP as well. Next slide, please. What are the doses recommended for PEP regimens? For all adults and adolescents above 10 kgs and more than 30 kgs of body weight, it is TLD, single pill, tenofovir 300 mg, lamivudine 300 mg, DTG 50 mg, rolled into a single pill. All of us know this. But in absence of DTG, we can always use TL-Lpvr, that is tenofovir, lamivudine, and lopinavir 200 by 200 and ritonavir 50 mg. There's a question: how much practical is to assess the prevalence? It's a good question. It depends on the case-to-case basis and depends on the severity of the percutaneous injury. It depends on that and depends on the consultation, depends on the consultant who is writing the PEP. It depends on that. Nothing can be 100% sacrosanct. It depends on you, doctor, who is going to write the prescriptions. If you think, you ask questions, go deeper into the question. And if you see if the patient was very, very sick, if the patient, if the source person was in a state of suffering from oral candidiasis, or he was in very, very sick condition or was admitted, it depends on that. So it depends on you, doctor, to write the PEP. So you have to use your wisdom to write the prescription and your experience. So let me come back to other alternative medication for adults and adolescents. If other LPVR and DTG are not available, you still can give TLE if it is available. But we know efavirenz is a truant, with its neurological side effects, and it can hamper with continuing with it, the PEP dose for 28 days. So this is in case you don't have the other drugs. Then counseling is a must. And for children above 6 years and above 20 kgs of body weight, sidovudine and lamivudine as per weight band, and DTG 50 mg. And if the hemoglobin happens to be less than 9 grams, according to NACO, we have to substitute zidovudine with abacavir, rest remaining the same. For children less than 6 years of age and body weight less than 20 kg of weight, we do not give dolutegravir according to NACO guideline. Instead of dolutegravir, we give lopinavir, ritonavir according to weight band. So we give zidovudine, lamivudine, and lopinavir, ritonavir. And if the hemoglobin happens to be less than 9 grams, you have to give abacavir, lamivudine, and lopinavir, ritonavir. And as I have said that, I have come across a lot of physicians holding back the PEP drugs till the exposed person gets his HIV test done, ICTC done. This is just not done, because you are wasting golden hours, because you are wasting the time. So whether he is infected or not, we don't know, but let him start a TLD, let him start the drug that is appropriately needed for him to prevent the HIV infection. So immediately start the medication, then ask him to go for the HIV testing of the source person as well as his baseline ICTC, and within 72 hours of exposure. But remember, it should be as early as possible. SCB should be counseled about safety of the PEP drugs, and duration is 28 days. We have spoken about it. Next slide, please. So management of minor AV drugs can be managed by the person who is writing the prescription. It is nausea, headache, diarrhea, fatigue. The one important thing is CNS side effects when it's about efavirenz. We know how to manage TLE. So this is very, very important. We can manage this. Rash, if there's rashes, then we have to think twice. Fever and jaundice, then we have to stop drugs. And if rashes, whether it's a wet lesion or dry lesion, we have to act accordingly. Here comes the role of an expert. So we have to get the help of an expert to manage these issues when it's beyond your capacity. Next slide, please. Hepatitis B vaccination has to be made mandatory for healthcare provider. It's part of safety of the healthcare providers. Everybody in the ART centers, all healthcare providers should be on hepatitis B vaccination. So let me read out. So Hep B vaccination status of exposed person never vaccinated, complete Hep B vaccination series, 0 day, 1 month, 6 months, vaccinated and anti-HBsAg, we don't know. Give Hep B vaccination booster. More vaccination done 5 years back. So give hepatitis B vaccine booster. But remember, testing for hepatitis B and it is not necessary. There's no provision. There's no facility in my institute. What do I do? Then we can go for Hep B vaccination should be given as soon as possible after the exposure. Do not for Hep B antibody results, HSCG results, if the test is done. Adequate level of antibody to HBsAg is above 10 IUL. Next slide, please. Lab evaluation. What are the baseline lab investigations? Timing. In person taking PEP, standard regimen. In persons not taking PEP. In persons taking PEP, standard regimen is HIV, HCV, anti-HBsAg, CBC, serum transaminase. Why do you go for HIV? Because if the person is already infected, he or she does not need PEP. He or she needs ART, antiretroviral treatment. So it is also a case of medical legal issues. So HIV baseline is very, very important. And in persons not taking PEP, we have to go for HIV, HCV, and anti-HBsAg. So, and HIV, Hep B, Hep C testing of exposed staff within 6 days of accidental exposure of blood is recommended. Baseline serostatus, as I have just mentioned. And the decision to test for HIV or not should be based on informed consent of the exposed person. I told you, in ICTC, it is always opt-in and opt-out phenomenon. You cannot force anybody. An exposed person is not liable to start PEP also. He or she can opt out as well. But we should counsel the patient. And good question. It is always important if you go for VDL and RPR. But at the baseline, if you know the person who's VDL or RPR positive, but single RPR without dilution doesn't make any sense. So we have to go for VDL or RPR with dilution. If it gives you, then you have to send the person to the Suraksha clinic or the STI clinic for further evaluation of the exposed person. And at the same time, HIV has to be done at 6 weeks after exposure, at 3 months and 6 months. Next slide, please. Follow-up of an exposed person. Whether or not PEP has been started, follow-up is indicated to monitor. Clinical follow-up, signs of acute seroconversion like fever, rashes, lymphadenopathy, pharyngitis, non-specific flu-like fever, swelling of the knee joints, and ulcers of the mouth or genital area. These symptoms appear, all we know is around 50 to 70% individual in primary HIV infections, and it happens within 3 to 6 weeks after exposure. And lab follow-up. Next slide, please. Clinical follow-up, I've just mentioned, 3 to 6 weeks after exposure, it might happen. And what are the things that has to be avoided? No blood donation. That's very important. No breastfeeding. Patient. Yes, we do test for HBs, anti-HBs routinely. Yes, we do. Blood donation, breastfeeding. Blood donation, breastfeeding, pregnancy has to be kept in mind. We have to avoid. Person should use precaution like in sexual relationship, like condom promotion. Out here, I want to mention, it is not about condom promotion only. It is correct and consistent use of condom. It is not I've used last time, so this time I can avoid. Not exactly so. It is always, remember these two phrases, correct and consistent use of condom. That has to be kept in mind when you're going for intimate relationship or penetrative sex. Adherence and adverse drug reaction counseling is mandatory, as I've just mentioned. It is very, very important. And the person has to come back if is the healthcare provider is not satisfied. He is in a state of panic. You have to counsel the person over and over again. And if possible, give them her or your phone number. Next slide, please. Recommended follow-up lab monitoring after PEP is timing. It is complete blood count, especially for zidovudine. We know it leads to bone marrow suppression, fasting blood sugar, random blood sugar for DTG, serum creatinine for tenofovir. We have to go for HIV antibody at 6 weeks, 3 months, and 6 months. Next slide, please. And what is the care pathway for PEP? We have to go for assessment. So assessment, we have to test for eligibility assessment for PEP, counseling and support, risk of HIV, risk of benefits and side effects and adherence, and prescription. PEP should be initiated as early as possible, definitely within 72 hours. Even if they come up 72 hours, we have to prescribe, and we can always consult expert people. And for 28 days, I have said, and follow-up is very important. Without follow-up, the umbrella is never fully open. You have to completely do with the follow-up till 6 months till the from exposure. Next slide, please. Preventing exposure to and transmission of HIV and other viruses. Next slide, please. Activities associated with needle stick or sharp object injuries. So you see, if you look at the pie chart, you see red. It's very striking. 52% is during use. Needle stick injury during use is around 52%, is more than 50%. So you see, there lies the devil. During use, we are not paying much attention. We are just being careless or overconfident. And yellow is others. And around is decided from the. It is from the time of exposure. It is from the time of exposure, sir. It is from the time of exposure. And during use, it is most of 52%. For other places, for after use is around 10%. You can read the slide. So it is 52. It's a 52% during use of needle sharp objects. So please pay some importance. Look into the issues while working with sharps. Next slide, please. What devices associated with percutaneous injuries by percentage? Look at the pie chart again. Disposable in syringe is around 24%. Suture needle is around 26%. Others are yellow, and other categories follows. So you say this is very, very important. And if you do not look into this, you cannot stop transmission of the infection to healthcare providers, and there lies a standard workplace precaution. We'll come to it next. Next slide, please. Practices that influence the risks of occupational exposure. Recapping of needle is very, very important. Why do you need to recap needles? You have a needle cutter. You have the manual or the electrical one. You have a needle cutter. You have the syringe destroyers. So use that. Transferring of body fluids between containers, we don't need to. And keep the needle cutter to the area where you are working. Handling and passing needles or sharps. What happens, I've seen people handing over the needles or the sharps while wearing gloves or barehanded. No, that's not the way. You use a kidney tray to pass on the needle or the sharps. Use a kidney tray. Chances of injury is less. And even if you have to use hold on to the sharp, take the sharp objects near you, and the handle should be on the other side. Failing to dispose of used needles properly in a puncture-resistant sharp containers, very important point. And the moment it is 3/4 full, get rid of, dispose. It should not overflow. This is the NACO diktat. That is for NACO. This is what the NACO has suggested. It should be 3/4 full, and you dispose of the needle. And do not wait till it is completely full and overflowing. And poor healthcare waste management practices has to be changed. Next slide, please. This is what I've just spoken about, but some people still do it. Next slide. Practices that reduce the risk of occupational exposure. Strict compliance with SOP standard workplace precautions. Avoid the use of injection where you can go for oral or other drugs. Avoid recapping of needles. Use needle cutters. Promptly dispose needles in appropriate containers. Report all needle stick injuries and sharp related things to the place where you're supposed to. Participate in training related to infection prevention. There should be a lot of training to healthcare providers, every category, from the cleaners to mortuary staff, lab, doctors, nurses, students, first year students, everybody. Use devices with safety features, recording and monitoring. Please do that. Next slide. Standard workplace precautions it includes hand washing before and after all medical procedures, safe handling and immediate use of sharp and disposal of sharp, use of protective barriers. We all know that, gown and an apron and glasses, goggles, gloves, and etc. Safe disposal of contaminated wastes. And we should know where to go for PEP and where to get the drugs, and need to complete the full course of PEP drugs. Next slide, please. And this is a picture of safety precautions. Need for IG therapy. In the next slide, please. And this is, I would come back. This is where we end. And thank you for thank you everybody. Thank you, Vitek, Sweta ma'am. Thank you, Kiran, and thank you, Shuparna and Shudipa, for helping us peacefully. And I'm sure Sweta ma'am will invite me again to be giving me a chance.
Yes,
thank you.
So please be with us for another 5 minutes. I'll just check if all the questions from the chat box have been taken up. Meanwhile, participants can unmute their mic if they have any questions for sir.
Hello, sir.
Yes. Good afternoon.
Nice presentation, sir.
Thank you, sir.
My question is, please tell me about hepatitis B immunoglobulin therapy if the source patient is hepatitis B positive or unknown cases, sir.
Absolutely. We do not wait for that. We immediately start hepatitis B vaccination. That is good enough, because we won't have immunoglobulins out in the ART center or in the hospital immediately. We can immediately start hepatitis B vaccination, sir. That would take care of this. Okay?
Okay, sir.
Okay, thank you.
Sir, one more question, sir.
Yes.
Sir, the hepatitis B vaccination doses, the subsequent doses, second dose is after 1 month.
1 month, and one is at 6 months from the 0 day.
And those periods are calculated from the first dose.
Absolutely, sir. From the first dose. Sir, okay. Are you from Odisha?
Sir, I am from Odisha, Bhubaneswar, sir.
Oh, wonderful. I had stayed in Odisha when I was very young. God bless you, sir.
Thank you very much, sir. Thank you, sir.
Thank you. Yes, Sweta ma'am.
Yes, sir.
Is there any questions, or may I end?
Nivedita ma'am, your question has been answered.
Yes, ma'am.
Yes. Okay. So all questions taken up, sir. Thank you so much. Any more questions from the participants? Please feel free to unmute your mic. No questions, sir. Thank you so much, sir, for joining.
Thank you,
and facilitating this session. We'll just run the feedback, sir. Give us 2 minutes. The feedback poll is now visible on your screen. There are 4 questions in all. All the participants are requested to please answer all the 4 questions.
Hello.
The next session will be held on. Yeah.
Ma'am, there's a question. I can say,
yes,
Rajesh Datta, are you from Murshidabad? Rajesh? He has written a question. Should we use ZL-LPVR or L-LPVR below 6 years of age? We should always use Zerovudin. Zerovudin is a much more potent drug than Abacavir. But remember, if the hemoglobin is below 9 gram%, we have to Abacavir. We don't have a choice. And NACO doesn't have DTG, although in the West, we have DTG in a pediatric formulation. But out here, we have to use LPVR with Zerovudin. But if the hemoglobin is below 9 gram%, we have to use Abacavir instead of Zerovudin. Clear? Okay.
Thank you, sir. participants to kindly note that next session is on 10th of February. That's next Friday. The topic is management of HIV exposed infant and children and management of newly diagnosed HIV infection in children, including ART initiation. In case participants would like to go through the chapter before attending the RDLS session, for those RDLS session is please refer to chapter number 3.1 and 3.2 of the national guidelines for HIV care and treatment. You can refer to this chapter before attending the RDLS session. So can we conclude the session now?
Absolutely. Thank you, everybody.
So much, sir. Thank you, everyone.
Ma'am. Thank you.